Hi, I'm Taryn Grom, editor of PharmaVOICE magazine, on the floor of the 2010 DIA annual meeting, and I'm here with Gary Slatko of ParagonRx, an inventive health company.
Gary, welcome to the PharmaVOICE Editors Take Video program. Today we'd like to discuss what some of the best practices are in developing a REMS program and how they differ per therapeutic class or type of risk.
Initially, when the FDA was originally contemplating its risk map guidance and REMS guidance, therapeutic area was one important consideration in how a REMS program got developed. And in fact, there were some therapeutic areas they were immune from needing a risk management program because the nature of the underlying condition was significant enough that a risk management program didn't make sense. But even the oncology area, which is the best known example of that, is now vulnerable to having REMS programs, as evidenced by the PRIZE program for the erythrocyte stimulating agents. So another way to think about it, probably more relevant, is the nature of the actual risks that are of concern. And the FDA specified certain risks that are important to them, that matter, that they want REMS programs developed for, such as QTc prolongation, LFT abnormalities, drug-drug interactions, teratogenicity, and the like. These were specifically mentioned in the FDA's 2005 guidance. But in fact, in practice, the vast minority of risk management programs with those issues have been about those topics, and they've actually covered more general or other kinds of risks not mentioned by the FDA. And in fact, FDA has actually migrated its authority even farther away from just looking at risks to things like off-label use, for example. The third way to think about this, and probably the most relevant, is does the FDA have confidence that a particular stakeholder is going to be able to do what they need to do to mitigate the adverse event? If a patient has a role in preventing the event from occurring, then the FDA needs to think about using a medication guide. If a healthcare provider is the one whose behavior needs to be managed, then a communications plan is probably in order. And of course, if both need those issues addressed, then both elements are needed. If voluntary or education is not deemed adequate, then something more controlling, like an element to assure safe use, is going to be needed. So in terms of best practices, the things that we advocate are first to analyze the care process for where the risks might manifest themselves, which stakeholder is the primary player in mitigating those risks, and designing your program directed towards those potential areas of vulnerability. Secondly is contingency planning. It's very important. The FDA is very unpredictable in what it's looking for, and the company needs to anticipate the possibility that anything can occur at the end of the process. Also important are the concept of non-REMS interventions. That is, risk mitigation educational materials that are developed by the marketing side of the organization that aren't required in the REMS program, but that actually help to mitigate risk. Fourthly is how the program gets implemented, and we advocate the use of a REMS coordination office to manage that implementation. The company should also think about how the product's going to be distributed, and if there's a specialty pharmacy element to the program, the company can use that as a way to target and distribute product only to the stakeholders for whom the product is appropriate. And finally, the area of assessment. We're at a critical stage with REMS these days, with the FDA looking at the initial assessments for multiple programs, and the assessment should be done not only to meet the minimum requirement that's committed to with FDA, but capturing additional information that the company can use to identify where the weaknesses are in the program and how to improve it.
Thank you so much for providing us with such in-depth knowledge about the REMS programs.
You're welcome. Thank you.